Hi guys, the first of these lectures is going to be about immunity, pathology, and vaccines. So these would be chapters 7, 8, 9, and also 11. Okay, remember how to use this program, sorry. The first thing I'm going to discuss is why we talk about immunity and pathology linked together, right? So we tend to think of immunity as being good and pathology as being bad. The reason why one would talk about pathology, hopefully that's obvious in a micro class. Infectious disease tends to result in pathology, which tends to generate disease. The reason we talk about immunity in infectious disease has to do with protection and resolution of infection or prevention of infection. To a lesser extent, you could make the argument that evasion of immunity is a good virulence mechanism. Hopefully you would have seen some of that in chapter 14. But mostly the point that I like to make about this is that immune responses are what create pathology. Anytime you see inflammation or you see any swollen tissue or destroyed tissue, necrotic tissue, oftentimes that is a direct result of the immune response. Okay, so we're going to talk about some immune cells, and I'm going to be very brief about this. Some of you were kind enough to share your immunology course schedule so I can see what it is that you've learned already, and if I interpret that correctly, you guys would have mostly learned about innate immunity thus far. Hopefully you learned some of the cast of characters, and particularly the professional phagocytes at this point then, but in case there needs to be a review, you have macrophages, neutrophils, and dendritic cells. These are the ones that are going to engulf foreign particles, have them encapsulated in a phagosome, have that then merge with something called a lysosome, which has a whole bunch of destructive enzymes in it. That then becomes something called a phagolysosome. This is going to degrade whatever was engulfed, and then the professional phagocyte is going to spit it back out. On the side of adaptive immunity, you have another whole cast of cells, some of which you guys may have met already, but if not, the majority of what we're talking about here are called lymphocytes. More specifically, B and T cells. To a lesser extent, natural killer cells. Lymphocytes are, in the case of B cells, responsible for producing antibodies. In the case of T cells, one subset would be responsible for orchestrating this entire adaptive response, and another set would be responsible for directly injecting toxic metabolites into infected cells that have an intracellular pathogen in them. So something like a cell that's infected with a flu virus. A T cell is going to glom onto an infected cell, squirt in some components called porphyrins and granzymes that are going to destroy that infected cell before it can burst and release a whole bunch of additional flu viruses. So again, this is something hopefully you guys have covered in your immunology class already, but an innate immune schematic, in my mind, would look something like this, right? So you have some infected cells. In this case, we have some erythrocytes that are infected with some mysterious circular pathogen. Those are going to interact with both dendritic cells and activated macrophages. What's going to happen then is they're going to produce a whole bunch of cytokines. Hopefully you guys are familiar with that term. But these cytokines are going to then start activating aspects of the adaptive immune response. Here, they're going to activate NK cells, which are going to come back around here and attack these. They're going to activate naive T cells. If they are CD4 positive or helper T cells, these are then going to start secreting cytokines of their own that are going to have B cells start proliferating, and B cells that are capable of making antibodies that are going to attack whatever this thing is when it's in its extracellular state, those are going to start dividing like crazy. That would be the activation of the adaptive immune response, but particularly the activated macrophages themselves are capable of secreting cytokines, but also mediating parasite killing directly, or pathogen killing directly, by secreting things like nitric oxide. Okay, so a quick schematic on the adaptive immune system. Again, obviously you guys are going to be learning about this in the coming weeks in immunology, but if you have an antigen-presenting cell or professional phagocyte, kind of consider those interchangeable terms, at least for my purposes. That's going to engulf your antigen, it's going to grind it up, and as opposed to spitting it out, as we saw on the previous couple of slides, it's going to present it in a receptor called an MHC class 2. Here's a little teeny piece of that antigen right there. A CD4 positive T cell, or a helper T cell, if it's got the right receptor that's going to recognize that thing right there, that's suddenly going to become activated, and it's going to start secreting cytokines like crazy, and it's also going to activate more macrophages. It's going to activate B cells that are capable of producing antibodies to this thing. We saw that on the previous slide a minute ago. And if this thing is an intracellular pathogen, it's also going to activate something called killer T cells, or CD8 positive T cells. Those are then going to do the trick where they go over to an infected cell and squirt in porphyrins and granzymes. Okay, so that's innate immunity and adaptive immunity. What does that have to do with pathology? Again, most pathologic lesions are a direct result of some kind of innate or adaptive immune response. So we saw on the previous few slides killer T cells coming in and resulting in cell death. Typically that's done in a controlled way through apoptosis, which is not going to give you a lot of pathology, but the activated macrophages squirting out nitric oxide, natural killer cells squirting on degradative enzymes, that certainly is going to cause you some pathology. Inflammatory lesions are also going to, they're by definition pathology. This is where you have a whole bunch of immune cells invading and infiltrating into a tissue. So this, what you see right here, this is a section of intestinal tissue. All of these purple dots right here, these guys, those are lymphocytes that have invaded into that tissue. That tissue is not supposed to be that big and that wide, but it has to actually swell in order for to make space for all of these inflammatory cells. Chronic inflammation on a pathologic level is typically characterized by invasion of lymphocytes, and you can see why that would be. To have a chronic ongoing problem, you're probably dealing with an adaptive immune response rather than an acute, an innate immune response. Sorry. In acute inflammation, something that happens immediately, hopefully you guys are familiar with that term from learning about the innate immune system, you're dealing with innate immune cells, as you could imagine. So that would be neutrophils, macrophages, eosinophils, things like that. Those are going to be seen here in red. What you'll also see in these lesions, and what you can see macroscopically, or in terms of gross pathology, is something called edema, which is swelling. You can see it right here. This is a case of staph cellulitis. So these toes right here that are very red and very inflamed, you can also see they're very, very swollen and full of fluid. The fluid that's in there is filled with inflammatory cells. The section that I have up here is one from C. diff infection. I'm not to keep hammering that one organism, but we've already talked about it, so I thought it would make a good example. This is a type of infection where you actually see both acute and chronic inflammation going on. Chronic inflammation would be the areas that were originally infected. Acute inflammation is where you have this organism spreading deeper and deeper into the tissue. Okay, so I want to talk a little bit about the process of infectious disease. This would be, I believe, chapter 15. But I don't have the book in front of me, so I don't know for sure. In any event, I want to talk a little bit first about inflammation, because you almost always get it during infectious disease. Inflammation, again, is part of innate immunity, but it really contributes to many of the symptoms of infection. So hopefully you guys learned about the cardinal signs of inflammation, being heat, pain, swelling, redness, and this fifth one that you sometimes see, which is loss of function. Heat during inflammation has a very obvious clinical correlate in terms of disease symptom, which is fever. Pain, you also see, this would be kind of this symptom called malaise, which is just kind of that achy, crappy, tired feeling that you have. Swelling is seen symptomatically as edema. We saw that on those nasty-looking cellulitis toes on the previous slide. Anytime you have a whole bunch of fluid swelling into the area, that we clinically call edema. And finally, redness, I have here marked as flush that you get during a fever. So anybody that you see who's got a high fever, very often they'll have bright red cheeks as well. But another good example of that is erythema that you see during rashes. And they've got an image right here of something called erythema migrans, pathologically speaking, but in layman's terms we call that a bullseye rash that you see during Borrelia burgdorferi infection. So this is the agent of Lyme disease. This is a very classic looking Lyme rash, but this redness here is due to local inflammation from this organism. So in addition to symptoms of an active infection, we can also have pathology coming from post-infectious pathologic processes. And I'm sorry, it looks like I'm missing a picture here, but what you can see is some antibody-mediated post-infectious problems. And there's a really great example of that from an organism called Strep pyogenes. This is the organism that causes strep throat. This organism has on its surface something called the M protein. It's a long, skinny protein. It's got a whole bunch of coils in it. And again, you find it all over the surface. Many people who have pyogenes infection make antibodies that are going to recognize this protein. That seems fine until you look structurally at myosin protein, which is found on heart muscle. For a rather large segment of the population, the version of myosin that they make, and I'm going to try to draw this with my finger and it's going to be sad, so bear with me. Oh, it's even sadder than I thought it'd be. The point is, it looks exactly like M protein, very structurally similar. So the persons in the population with this variant of myosin, if they are infected with strep pyogenes and make antibodies to M protein, their antibodies that they make to strep are going to bind onto heart myosin, and that is going to cause an autoimmune response that wouldn't happen in the absence of them being infected with this organism. The end result of that is something called rheumatic fever, where they have antibodies binding onto heart muscle. And what ends up, let's see if I can make this bigger, it's not working, shoot. What ends up happening there is you get these inflammatory lesions in the heart because antibodies bind onto it, macrophages try to engulf it, they can't engulf entire cardiac myocytes, and so they wind up just degranulating all over the heart, and you wind up with these just terrible inflammatory lesions. Okay. So looking at cytotoxic responses, so these are T-cell responses now to different types of pathogens. What you typically see here, and where you typically see cytotoxic T-cell responses, are with intracellular pathogens. 9 times out of 10 when we say that, we're talking about viruses. So a person who has an infection with a virus is almost always going to have a killer T cell response or a CD8 positive T cell response. What happens here is you have an activated T cell. It's got a T cell receptor that's going to be specific for a certain epitope. You have a virally infected cell that's going to be presenting pieces of viruses on a receptor called MHC class 1. Don't confuse that with MHC class 2, that's on antigen-presenting cells. When these two things lock together, this T cell becomes activated. When it becomes activated, it starts squirting perforins and granzymes into this infected cell. This T cell becoming activated in the presence of being coupled to MHC1, this is important because a lot of pathogens manipulate this process as a virulence factor, and we're actually going to talk about one of those a little later on. I do just want to make sure that everybody takes away, even though I mentioned viruses 2 or 3 times, there are intracellular bacteria that generate CD8 positive responses. Mycobacterium tuberculosis is a great example of that. We actually met him in the first class when we were talking about the PPD diagnostic test. There are also intracellular parasites. Plasmodium falciparum and other Plasmodium species that cause malaria are good examples of those. Okay, I really hope I didn't just screw up this entire thing, because my app did something weird. But anyway, cytotoxic responses to different types of pathogens. I'm sorry, that should say antibody. Pretend this says antibody. Responses to different types of pathogens. Usually you see antibody responses to things that are exclusively extracellular pathogens or things that have an extracellular phase. So you do see antibodies to some intracellular pathogens. For example, most of us probably have flu antibodies and rhinovirus antibodies. Those are made due to their extracellular portions of the life cycle, say when you're contracting them or when they're spreading from one cell to another. But everything that is exclusively a surface/extracellular pathogen is going to have a B cell response associated with it. So B cells, once they've been activated, fall into one of 2 categories. Once they've been activated, after infection resolves, they'll become memory cells, meaning they have a low-level population, and these can be stimulated to reactivate and come back into their active phase again. And the active phase of B cells are called plasma cells. You see these guys you see these guys forming and replicating during active infection, and these are the type that actually spit out antibodies. The purpose of antibodies during infection is to adsorb onto the surface of an antigen, and in the ones that we're interested in, these would be pathogens. And then macrophages come along, bind the end point here, the Fc portion of these antibodies, and opsonize them, gobble them up, clean them up, and then that becomes dead. Okay, so antibodies are not one single type of molecule. They come in 5 different flavors. We have IgM, which is actually a pentamer of 5 separate antibody molecules. We have IgG, which is the diagram that we all sort of think of when we think of antibodies, this Y-shaped diagram. We have IgA, which is a dimer, which is there's one here, and they're linked together by this bit right here, which is called a J chain. And then IgD and IgE are also this monomeric shape, but their stock is somewhat different. Okay, so now I want to talk a little bit about immunization. which is kind of a blanket term for the creation of immunity. And I should say, by immunity, I mean sterilizing immunity. Immunity where, if you have it, you will not be infected by a particular pathogen. And a question I want to pose to you, are the terms immunization and vaccination interchangeable? We tend to use them that way in popular language, but I argue they're not, in fact, interchangeable. Immunization comes in two flavors, passive and active. Passive immunization means somebody is giving you antibodies. And we actually discussed one of these last week when I showed you this picture right here. So, pharmacologically speaking, you can passively immunize a person who's been exposed to something like rabies or something like tetanus. You can give them a serum of already pre-made antibodies. You are immunizing them when you do that, but you're just doing it passively. Active immunization is where you expose a person to something to stimulate them to generate their own immune response. In one case, the case of active, you'll have a memory response. You'll make memory B cells out of that. And you'll have lasting immunity. In the case of passive immunity, that doesn't happen. You're transiently giving somebody an immunity to a particular pathogen, but you're not giving them lifelong immunity. Incidentally, you can do this naturally as well if you are of the female persuasion, because you can do it by breastfeeding an infant. Okay, so this is a diagram taken from chapter 11 of your book. I actually like it okay, because it really simulates this idea of passive versus active. If you look at all the ways that you can passively immunize somebody by giving them a pharmaceutical intervention, you can give them purified IgG, you can give them whole serum. This was done, that we heard about in the news this past fall, when Ebola patients were given blood transfusions from patients who had recovered. And most specifically, the nurses in Dallas, Nina Pham and Amber Vinson, were given serum immunoglobulin from Dr. Kent Brantley, who was the first patient brought back to the U.S. and treated at the CDC for Ebola. Neither here nor there. Specific immunoglobulins are sort of a mixed population of antibodies that are all going to recognize one thing, but they've been purified and cleaned up. That would be the rabies IG I showed you on the previous slide. And you can also give somebody monoclonal antibodies, which are same idea, but they're going to specifically recognize just one epitope on a pathogen as opposed to all the epitopes. So active immunization, again, falls into multiple categories, and I'll go through these more specifically. But you can have inactivated vaccines, or you can have live vaccines. Inactivated fall in a few categories. You can have killed things, you can have pieces of things, you can have parts of things. Or you can have inactivated parts of things. Live falls in the category of attenuated mutants if you're doing intentional vaccination. But one thing I would point out to you is that immunization with a live pathogen can include this, right? You become immunized, you acquire immunity by getting sick and then recovering. This just is not done as a pharmaceutical intervention. It's done naturally. Okay. So, the first type of vaccine I want to talk about are whole cell vaccines. And you can have live ones or you can have inactivated ones. Live attenuated whole cell vaccines are made attenuated in a few different ways, some of which were on that diagram, but they include generating temperature sensitivity so that a live pathogen doesn't survive well in the human body. They include cold adapting pathogens, which is very, very much the same idea. Temperature sensitivity has the added feature of particular virulence factors not being expressed at human body temperature. You can also attenuate whole pathogens by adapting them to culture. If they survive well in culture and they lose their competitive ability to survive in a host, then they tend to lose the capacity to cause disease as well. Okay, there are some risks to these, there are some benefits to these. The benefits are that you tend to get I'm sorry, I'm getting like 5 emails and it was distracting me. The benefits from live whole cell vaccines is that you tend to get very good protective immunity from them. You also tend to get immunity that's more appropriate to the response. You can get mucosal immunity from live viruses that infect a mucosal surface, and that is going to protect you somewhat better. The immunity also tends to have a longer shelf life. You tend to have lifelong immunity that way. The risk to them, of course, is that you're injecting somebody with a live pathogen. If a person has a particular immunosuppression, that's not good. You don't want to give them that. If a person also happens to share a household with a person who is immunosuppressed, they can shed their live vaccine strain for a few days. And so if you have a perfectly healthy person who shares a house with an AIDS patient or a chemo patient or a 90-year-old great-grandmother, then you would not want to be giving them a live attenuated virus. The patient themselves would be fine, but they would shed on their household contacts who would not be. An inactivated whole cell vaccine is a bit of a different story. These are whole pathogens that are inactivated, usually by treatment with formalin. This is where the urban legends about injecting babies with formaldehyde when you vaccinate them comes from. What you're actually injecting them with is a pathogen that has been formaldehyde treated. Formaldehyde is thoroughly washed away before commercial packaging. There were attempts, and have been attempts, to heat inactivate certain pathogens to make vaccines. However, when you do that, you destroy a lot of what are the native protective epitopes, and so that does not work as well as formalin inactivation does. Right, there are risks and benefits to this too. The benefits is that you mitigate the risks of using a live vaccine, right? So a person who's injected with, say, the IPV, pictured right here, this person cannot shed live poliovirus because they haven't been infected with any. This person is not going to then transmit it to somebody else. The person is not going to get infected themselves if they have some kind of immune suppression. The problems with these, and risks is a bad term, the problems with these is that the immunity generated from them does not tend to be as robust as that of a live attenuated vaccine. In addition, these typically have to be administered with something called an adjuvant. And an adjuvant is a component that is given that's going to enhance and create a more robust inflammatory response to stimulate the immune system to respond to the specific antigen you're giving, which by itself is not spectacularly immunogenic. Adjuvants have, again, by design, they make an inflammatory response, and so that's where you tend to get a little bit of pain at injection site, fever, things like that. If you think about the last time you got a tetanus shot or if you've gotten one of these, I know myself, if you travel to Africa at some point, you will typically have to get an additional polio booster as an adult, and that sucker hurt. That hurt more than a tetanus shot did. Okay. Subunit vaccines do not involve administering a whole pathogen, as you can tell, and they fall into two categories. The first are peptides, and the second are polysaccharides. The idea here is that you're just giving a little piece of a vaccine. Peptides, peptide vaccines are the administration of short peptides from an immunogenic protein. So what you have to do if you would like to design a peptide vaccine is that you have to actually look at the protein sequence of a particular pathogen. This would be an example of that. So you have to know the genome sequence, and have to be able to translate that into protein sequence. You can look at these and predict which ones look like they're going to be immunogenic, and then you synthesize them in a laboratory, purify them, and try them out. See if they are in fact immunogenic by doing animal studies and then ultimately human studies. And so of an entire protein, you may only wind up with a couple of peptides that work well as immunogens. On the market that seem to work very nicely. The first is the hepatitis B vaccine. Works brilliantly well. It's really, really reduced the global burden of hepatitis B and its associated problems, which include liver cancer and liver transplant. Another that just came out on the market is something called Gardasil, which is a vaccine that protects against certain serotypes of HPV, or human papillomavirus. So this virus, in and of itself, does not cause that big a problem. It causes skin warts. Doesn't seem to be that drastic. However, these sets of serotypes are associated with and directly cause cervical cancer. In addition, they also cause penile cancer. They also cause head and neck cancers. So it's not just women who would be well advised to explore this vaccine. There are some small number of risks and a lot of benefits to peptide vaccines. Some of the risks or problems with them is that they tend to, again, create a sort of an artificial sense of immunity. It is only this section right here where immunity is created from this entire viral pathogen and this one. And so you could have these pathogens sort of escaping the immune response generated by the vaccine, and then the vaccine wouldn't be effective anymore. So far, at least with Hep B, that has not seemed to happen, which is good. With Gardasil, it hasn't been in widespread use long enough to really make that assessment. The benefits to these are they're very, very safe. There is never, was never, will never be an infectious agent associated with this. So they're not killed. There's no way that you can wind up getting these diseases by taking these vaccines. Very safe. Okay. The next type that we want to talk about are polysaccharide vaccines. So the ones that I wanted to discuss here specifically involve this thing right here, a polysaccharide capsule. So each one of these gray balls in the middle, these are bacterial cells, and the shady bit around them is a slimy layer of secreted polysaccharides, secreted sugars. These are important in virulence because they really seem to trip up macrophages. Macrophages has a very difficult time engulfing and opsonizing these guys. They protect the surface of the cell from antibodies against proteins. But the problem with that for the bacteria is that humans have now become quite good at making antibodies to the capsular polysaccharides themselves because we've started making vaccines out of them. Okay, so designing these is a little bit trickier than designing these. And the reason being is that we can't quite look at a genome sequence and say, oh, that looks like it would be an immunogenic polysaccharide, and then just make it in a lab. What we ultimately have to do here is look at circulating strains of pathogens with capsules on them and see what types of polysaccharide combinations are there, because certain pathogens really vary their types of capsules. For example, this guy right here, Strep pneumoniae, it has probably close to 100 different types of sugars that you can find on the surface, 100 different serotypes. And what we do here with this vaccine called Pneumovax 23 is that they took the 23 most common and combined them into a vaccine. So the design of these ends up being quite a bit of epidemiology. The synthesis of them is also a little more tricky than synthesizing peptides. It's biochemically harder to do. And so if you're interested in vaccines, and you being pharmacy students, I don't know if you are or you aren't, but there will be a lot of jobs for you if this topic interests you. Okay, so the risks and problems of these are very similar to those up here. Is basically what they include are the idea of not having complete immunity to this disease, and the idea that in this case you have happening what we were afraid of up here, where you have certain polysaccharide antigens that are in the vaccine. They weed those ones out of the population, and then the remaining say Strep pneumoniae strains that aren't covered by this vaccine, they move in and take over because the vaccine doesn't protect against them. And so you still have people having Strep pneumoniae infections even though they are vaccinated, because their capsule is of a different serotype than the one in the vaccine. So that's a problem with these guys. The benefits, again, are that they protect very, very well against the serotypes that they target, and they're very safe. As with peptide vaccines, these are made synthetically. There are no live organisms involved here. And the three that we're dealing with that are commonly used, Haemophilus influenza B, the meningococcal vaccine that some of you may actually have had when you went to college, and Pneumovax, all three of these organisms cause not only ear infections, which are a nuisance, but all three of them cause meningitis, which is a terrible disease. So having a vaccine to prevent that is critically important. Okay, so who gets which vaccines? The first thing I want to mention is the standard childhood vaccine series. So this is the one that we hear about all the time, the idea of getting pertussis and tetanus and diphtheria and polio, and now you get Hib or Haemophilus influenza B, you get chickenpox, you get MMRs, all those. Those are given to all immunologically normal, or all more or less, quote, healthy children, provided it is consented to by their parents. The idea there is that it's going to create a certain level of immunity within the population, so that it's going to protect the members of the population who are unable, medically speaking, to receive the vaccines. Okay, so another thing that's done here is to give vaccines to at-risk populations only. So some of these are recommended specifically for the elderly. There's a shingles vaccine, prevents against varicella zoster virus, or VZV. Very much the same formulation as the chickenpox vaccine that children now get, and actually you people probably got when you were little. But in the case of the elderly, it protects against shingles, which they're at high risk for. They also get pneumavax. The elderly tend to have very strong complications from pneumonia, so it's good to try to prevent them from getting that if possible, although, as we mentioned before, there are plenty of pneumo strains that aren't covered by this vaccine. And it's also recommended that they get seasonal flu shot every year. These two go together very nicely. Influenza, particularly in people with compromised immune systems, such as the elderly, very frequently can be followed up by bacterial pneumonia, and then that has a disturbingly high mortality rate. So if you vaccinate an at-risk person, such as an elderly person, with a seasonal flu and a pneumovax, you really cut the rate of pneumonia deaths quite substantially. Oh, all of my things just did not line up well when I transferred this file over. Sorry about that. This is supposed to be looking at people with disease complications. And two very clear examples of that are asthmatics, who are nearly always recommended to get seasonal flu vaccines so that they don't get influenza and wind up with 6 months of asthmatic complications from that. And I definitely want to draw your attention to this idea right here, that we've got two different pictures here, and that's because flu shot comes in two different forms. You have a formalin-killed flu shot, and you have a live attenuated nasal spray mist. The reason why I put them in two different places is that the elderly, being immunocompromised, you would definitely not want to give them this live attenuated flu shot. You would want to give them this killed one. It's safer for them. And asthmatic is going to be perfectly fine to get flu mist. Okay, another great example of this is hepatitis C patients, of which we have a very large number in this country and around the world. If you have Hep C and you're at high risk for developing complications of chronic hepatitis, such as cirrhosis, such as liver cancer, you darn well better get a Hep B and a Hep A vaccine, because the last thing you would want is an additional hepatitis virus in your system. The last targeted point that I want to make is that there are certain vaccines that are almost exclusively reserved, at least in this country, for travelers. So there is no reason for somebody who is not going to an endemic area, for example, to get the yellow fever vaccine. If you are going to an endemic area, be South Central America, and parts of Southeast Asia, you would be very well advised to get this vaccine. Same deal for the typhoid fever vaccine. In these two over here, people often are receive in this country, but they are often brought up at travel clinics as well. If you go anywhere, particularly in North Africa, that's a part of the world called, cutely referred to as the meningitis belt. Very high rate of meningitis. So if you've not received this vaccine and you plan on traveling there, you will definitely get it at the travel clinic before you go. Hepatitis A is given to travelers going to parts of the world where they have high rates of foodborne illness. So that would be your Chinas, your Indias, your Central Americas, if you will. I didn't put it on here, but one other target that's important to bring up would be people with occupational risks, and the classic example of that would be a veterinarian getting a rabies shot. You don't need the general population to have rabies shots, but certainly somebody who's exposed to a lot of animals, it would be a good idea. Okay, so that's all I have for vaccines, and I will be back with another recording shortly.